Hey everyone, let's jump right into this high-yield explainer on Legionella infections. Look, if you're gearing up for medical exams, you are exactly where you need to be. Test writers absolutely love to trick students on this two-faced pathogen, so we're going to lock down exactly what you need to know to ace those tricky clinical vignettes.
Here's our quick roadmap for today. We're going to meet the pathogen, compare Legionnaires to Poniac fever, spot the clinical clues, dodge the diagnostic traps, nail down the targeted treatments, and finally, look at outbreaks and prevention. Let's get to it.
Starting with Section 1, let's meet the pathogen and cover the microbiology and transmission basics.
So to truly understand how this bug infects us, we really need to understand where it lives. Legionella is an aerobic, gram-negative bacterium. But here's a massive clinical pearl right off the bat. It stains incredibly poorly on a standard gram stain. You're going to need a silver stain or direct fluorescent antibody to actually see it in tissue. Now, out in the wild, its primary habitat is actually inside amoebae in aquatic environments. We humans, we're just accidental hosts. We get infected by inhaling these tiny aerosolized water particles. We're talking less than 10 micrometers, from contaminated sources. Think cooling towers, hot tubs, hospital shower heads, or even those water misters at theme parks. And while there are over 60 species out there, Legionella pneumophilus serotype 1 causes over 80% of all clinical cases.
Which brings us to a huge exam trap. You have to remember this. Legionella is not spread person to person. Literally, aside from one single presumptive case ever reported in all of medical history, you cannot catch this from another coughing patient. You catch it directly from the environment.
Okay, moving to Section 2. Legionnaires versus Poniac fever, the core conflict.
This is so fascinating because this single organism causes two wildly different clinical presentations. Seriously, when you put them side by side, it is night and day. On one hand, you've got Legionnaire's disease. This is a severe atypical pneumonia. These patients often end up in the ICU, and it absolutely requires antibiotics to clear. But on the other hand, we have Pontiac fever. This is just a mild flu-like illness. The absolute key distinguisher here, there is zero pneumonia in Pontiac fever, and it's totally self-limiting.
But get this, here's the crazy part. Poniac fever has an unbelievably high attack rate of up to 90% among exposed persons. If a room full of people is exposed to a contaminated mist, almost everyone is walking out with Poniac fever. Compare that to Legionnaire's disease, which has a super low attack rate of only about 5%. And these two diseases operate on completely different timelines. Poniac fever hits fast and leaves fast. It's got an incubation period of just 24 to 48 hours, and a swift recovery in 3 to 5 days. Nobody's going to the hospital for this. Legionnaire's, though, it simmers for anywhere from 2 to 10 days before showing those severe symptoms, and the recovery is really prolonged, with over a quarter of patients suffering long-term complications.
All right, Section 3, clinical clues and hallmarks. Let's talk about spotting the atypical.
So how do we spot this specific bug in a really busy clinical vignette? Well, like other atypical pneumonias, you're going to see the basics: fever, muscle aches, headache, and a cough. But the test writers, they want you to look for the bizarre add-ons. If you see a patient with pneumonia who is also confused, or maybe they're having nausea, vomiting, and diarrhea, ding, 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 neurological and GI symptoms packaged with pneumonia are a massive red flag for Legionella. Oh, and be hypervigilant with immunosuppressed patients. They might not even mount a fever, so you've got to keep your clinical suspicion super high.
But the most crucial point is this absolute hallmark lab finding: hyponatremia, low sodium. If an exam question gives you a patient with atypical pneumonia, confusion, diarrhea, and hyponatremia, you are dealing with Legionella until proven otherwise. Literally, lock it in.
Let's jump to Section 4, diagnostic tests and traps. This is how they test you.
Honestly, this is arguably the most heavily tested area of this whole explainer, because the real world is just full of diagnostic pitfalls here. Let's quickly break down your testing arsenal. The urinary antigen test, or UAT, is your most widely used, go-to practical test in the community. It's rapid, it's simple. But for investigating outbreaks, culture on a special agar called buffered charcoal yeast extract, or BCYE. That is your gold standard. It lets public health officials serotype the bug and actually link it to the environmental source. Now, if you need the absolute most sensitive test for a sputum sample, you're going with PCR. And serology? Honestly, it's really only useful for retrospective diagnosis, mainly because you have to wait around for a 4-fold rise in antibodies. But watch out, because here is the trap they are definitely going to set for you. The urinary antigen test only detects Legionella pneumophilus serotype 1. That's it. It completely misses all other species and all other serotypes.
This is incredibly dangerous if you're dealing with an immunosuppressed patient, because they're much more likely to be infected by a non-serotype 1 strain. Bottom line, a negative UAT does not definitively rule out Legionella.
Section 5. Targeted treatment strategies. Let's talk about hitting the target.
So we know what the bug is. Now let's figure out the why behind the drug choices. Ask yourself this: why do our standard beta-lactam antibiotics, your go-to penicillins or cephalosporins, completely fail against Legionella? Any ideas?
It's because Legionella is an obligate intracellular pathogen. Remember how we said it naturally lives inside those aquatic amoebae? Well, in the human lung, it uses the exact same survival strategy. It invades and replicates right inside our alveolar macrophages. Since beta-lactams and aminoglycosides just can't penetrate those intracellular compartments, the bacteria are completely shielded, rendering those drugs totally useless in the clinic.
So you've got to use antibiotics that actually achieve high intracellular concentrations. Azithromycin is typically your preferred macrolide because it easily penetrates the cell and shuts down the bug's protein synthesis. Fluoroquinolones like levofloxacin or moxifloxacin are also fantastic choices because of their potent intracellular activity. For a standard community-acquired case, you're going to treat for a minimum of 5 days after the patient achieves clinical stability.
But wait, this brings us to another massive exam trap. Do not give these strong antibiotics for Pontiac fever. Seriously, Pontiac fever is a mild, self-limiting illness. It resolves in a few days on its own. It requires absolutely zero antibiotic therapy. Just treat the pneumonia cases and let the Pontiac fever run its quick course.
Finally, Section 6, Outbreaks and Prevention. Let's look at hospital management.
Stopping these infections before they start is a massive priority for public health. And why? Because of this number right here. While community-acquired Legionella has about a 10% mortality rate, nosocomial, meaning hospital-acquired Legionella, carries a staggering 25% case fatality rate. We're dealing with vulnerable, immunocompromised patients here. And worse, if you delay their treatment, that mortality rate literally triples.
Because the stakes are so incredibly high, the rules are strict. All healthcare organizations are mandated to have rigorous water management plans. Facilities have to conduct biennial or quarterly environmental testing by culturing their water systems on that BCYEA agar we talked about. If an outbreak does happen, immediate steps include limiting water exposure, performing a system-wide heat shock, or using hyperchlorination. And of course, keeping those massive cooling towers routinely disinfected is absolutely non-negotiable. So I'm going to leave you with this final, really provocative engineering challenge that hospitals face every single day. How do we balance keeping water temperatures low enough to prevent accidentally scalding patients while keeping them hot enough to prevent Legionella from thriving in the pipes? It's a real-world puzzle, and it just shows you how impactful this high-yield microbiology is to everyday medicine. I really hope this explainer locked in those tricky distinctions for you. Keep studying smart, watch out for those testing traps, and we'll catch you in the next one.